Joining us now is Dr. Michael Daignault. He is an emergency physician at Providence St. Joseph Medical Center in Los Angeles. It is live. Doctor, I don't know whether to say good morning or good evening. I know it's 2:30 or whatever in the morning. Thank you. It's an incredibly important conversation. You and I have been going back and forth a bit on Twitter, reading your op-eds in the Washington Post and elsewhere. What are you and your team seeing on the ground in your hospitals right now?
Good morning. Thank you for having me on. As you mentioned at the outset here, the ICUs are definitely not as full as they were last winter. I remember last winter during the winter surge that we had in LA, when LA was essentially the epicenter of the pandemic, we actually had an extra doc scheduled at night from 7 p.m. to 7 a.m., either an ER doc, a pulmonologist, or an anesthesiologist who would respond to all the code blues in the hospital of admitted COVID patients in the ICU and telemetry floor that went to cardiac arrest or respiratory arrest. And, a lot of us still have a lot of PTSD from that. And, we certainly don't want to go back to that state. And so right now we're certainly seeing a lot of patients admitted who may require some oxygen for a few days. But, Bloomberg released an article earlier this week that only, 64% of the ICUs are filled with COVID patients relative to last year. So it's definitely an improvement.
We had an interview with Dr. Sharif El-Nahal of University Hospital in Newark yesterday, and we asked him a direct question and said, what percentage of your COVID patients are there for COVID or with COVID? Doctor, I don't need to tell you. This is a big debate right now. The governor of New York State is talking about better hospital accounting. How do we know who's exactly there? What levels are you seeing with COVID, for COVID?
Yeah, Brian, this has been, one of my pet peeves lately. And, the United States has always been weakest on data relative to other countries. And this is certainly an area right now where we really need to figure out what is going on with hospitalizations. We saw in South Africa, we saw in the UK that there was a decoupling between cases of COVID and hospitalizations. And then we saw multiple 6 lab studies that showed that Omicron was not as effective as getting into the lung tissue as, say, Delta and previous variants. And so I think we expected to see that similar decoupling between cases and hospitalizations here. And starting with New York, we weren't seeing that. And then that led me and, Dr. Monica Gandhi to start investigating and try to figure out why aren't we seeing this? And I think one of the possible reasons, in addition to us still having a bit of a Delta surge earlier on in November and December that contributed to hospitalizations, was that our data is not great. We don't particularly differentiate between who is admitted primarily for COVID or who just happens to test positive. We test every admitted patient from the ER using a PCR test, which, as you know, could be positive anytime in the last 90 days, and begs the question whether we should actually be doing rapid tests in the ER as well. And so, the LA County hospitals last week released that report that 2/3 of patients admitted were for incidental COVID. And so I really think it's really important. We owe it to ourselves. We owe it to our policymakers to have a better idea of the hospitalization data, particularly who's requiring ICU level care and who is just requiring a monitored telemetry bed, for example.
Well, it's an excellent point, because what we have learned about PCR testing, which I guess they're considered the gold standard, is that they can stay positive, to your point, doctor, for months after you're basically not infected and you're not spreading the virus, but you have a tiny amount in your nose. But let me ask this. Maybe it's a stupid question. If I come in with a broken knee from a skiing accident in Big Bear, why am I being tested for COVID anyway?
Yeah, it's just hospital policy across the country that we'd like to keep people who are positive in certain floors, different parts of the hospital, just to keep the cohorts the same. That's just been the policy throughout COVID. But your example is an excellent one, where there was a traumatic accident. We know that if you test positive, it's probably not contributing to your hospitalization. Now, that being said, certainly in the ER, it's just a snapshot in time of a patient's experience. And if they get admitted to the hospital and during the course of that hospital visit, the admitting hospitalist physicians determine that a patient's congestive heart failure or acute COPD exacerbation was caused by that COVID infection, then those numbers can be updated. This is a dynamic process. And so I think that's what we need these hospitalization data to better reflect.
And there's not much. I've been trying. I don't know if you follow me on social media. I think you do, Doctor. I've been trying to dig through the data on this. My wife is basically ready to commit me because she's like, you're obsessed with this. I think it's an important thing. I mean, the headlines and to be frank, the TV media is a hospitalization soaring. Well, we just need to know why and what for. Iowa, North Dakota, really the only two states that break it out. Tennessee yesterday said they're going to stop reporting daily cases and hospitalizations at all. They're going to go to a weekly model. Let me ask you this, doctor. What can we in the media do better about reporting on this and understanding this? Because I'm trying and it's hard.
Yeah, I think what you're doing, I think, especially on the social media with Twitter and pointing, and I'm doing the same, is pointing out who is leading us in giving accurate hospitalization data. Like you mentioned, the governor of New York calling for proper accounting, the other states that you mentioned, certain healthcare systems and hospitals reporting data saying these patients are admitted primarily for COVID and these are incidentals. UCSF has a great system where they actually go even further and differentiate who is admitted to ICU, and within that, who is requiring mechanical ventilation. I mean, this has very important considerations for hospital administrators as far as staffing. I mean, you talked earlier in your broadcast about the burnout issue that we're having. And, if we're having less COVID patients this winter requiring mechanical ventilation, that means that you don't have to worry about overstaffing respiratory therapists, who are a critical component of managing patients on the vent. And we want to make sure that ICU nurses don't go above that 2 patient per nurse maximum that they're supposed to have. So this is data that, everybody could use.
And to your point, it's a shame that it's so decentralized. You think, Amazon knows what you and I want to buy before we even do. You think that we could get this hospitalization data down to a science where we can really, truly figure this out. But we do appreciate your on-the-ground reporting, appreciate more the work you do as an emergency room physician, doctor. Thank you. I'll let you get some sleep, but we really appreciate you staying up for this late conversation. Thank you.
Thank you for having me.